you very much. And thank you to the organizers for the opportunity to present. I have no disclosures. So starting with some backgrounds. So the brainstem comprises just 2% of brain volume, but it's a location of something around 5 to 10% of brain metastases. Due to the presence of multiple important neurologic pathways and structures within a small space, the brainstem is a sensitive location. And historically, patients with brainstem metastases were perceived to have a poor prognosis. For these reasons, among others, patients with brainstem metastases were excluded from some early trials of radiosurgery. Because surgical resection can be challenging or not possible for many patients. And so for many patients, stereotactic radiosurgery or SRS is the only means of local treatment for brainstem metastases. So some of the earliest reports of SRS for brainstem metastases come from the University of Pittsburgh in the 1990s, with the first sizable series published in 1999. Since then, there have been multiple small retrospective reviews owing to the kind of rarity of brainstem metastases, limited to something around 20 to 40 patients. These studies have variations in dose, modality of stereotactic radiosurgery, as well as some variation in outcomes and toxicity levels. Owing to the lack of prospective studies in this space, some clinical trials continue to exclude patients with brainstem metastases from their trials. So the aim of our study was to try to summarize these the existing literature around the efficacy and safety of SRS for brainstem metastases in a meta-analysis. So here's our study design. We performed a search of PubMed and Embase databases. Our inclusion criteria were studies with at least 10 patients and reporting at least one of our outcomes of interest. And using this procedure, we identified 32 articles, which we eventually included in this study. Here are the characteristics of these studies included. So in sum, about 1,500 patients in 32 studies were included. In general, these patients had a relatively high performance status. The median follow-up was about 8.5 months in these studies. The majority of patients had lung, breast, or melanoma histology. The majority had other brain metastases in addition to the brainstem metastasis. And most notably, these were very small metastases with a median size of 0.4 cc's. And that's a typo, it should say 0.7 centimeters as a kind of what a sphere of 0.4 cc's might look like. Treatment characteristics, most patients received gamma knife to a median dose of 16 gray and 1 fraction. And so that's lower than our typical dose that would give to brain metastases in other locations, which are more along the lines of 18 to 20 gray. This is summarizing the primary outcomes. So pooling all of these studies together, we see that the 1-year pooled local control was 86%. The pooled objective response rate, so this includes complete and partial responses, was about 60%. Among studies that reported on this, symptom improvement was seen in about 55% of patients. And then the survival outcomes were reflective of an era before molecular therapies were available. And so prognosis was poor with a 1-year survival of 33%. And a neurologic death rate of 24%. As comparison, we also pooled 5 of the major prospective SRS trials, which showed a 1-year local control of about 81% together, and a neurologic death rate that was similar of 21%. Next, summarizing the toxicity reported in literature. Grade 3 to 5 toxicity was rare with 2.4% as a pooled rate. Symptomatic toxicity of any grade was seen in 5.6% of patients. And then among toxicities that were reported that were able to be linked to histology, interestingly, it seemed like melanoma and renal cell were more predominant than would be expected. Concordantly on meta-regression on a study per study level, melanoma histology, so greater proportion of melanoma histology correlated with greater toxicity. Dose and size did not quite reach significance. However, numerically, the median size of lesions experiencing toxicity was larger than in the general cohort. So all this to say that Brainstem SRS for brainstem metastases seems to be safe and efficacious. And so kind of bringing it back to a clinical case. So this is a patient that was seen in 2021 at UCSF, a 70-year-old male with presented with left-sided numbness, was found to have multiple brain mets, including one 1.5 centimeter one in the pons. So notably, this lesion was approximately 10 times larger than the median size of the lesions that were studied in these other studies. So this patient actually underwent a staged SRS treatment where he had the first dose of 10 gray while in the hospital, at which time the lesion was 4.5 cc's, returned 3 weeks later as an outpatient to receive his second dose, at which time a partial response was already seen. And then finally, 2 weeks after that for his final dose, at which time a significant response was already being seen. Eventually went on to have a complete response with no apparent toxicity, is doing well about 7 months out. So takeaways and conclusions, SRS for small brainstem metastases led to high local control and very low toxicity, which compared favorably to trials of non-brainstem metastases within in the brain. SRS to a lower than usual dose, is a median of 16 gray, was still efficacious in this cohort of smaller tumors. I wanted to highlight some ongoing trials. So one trial that was presented this year at ASCO was actually an SRS de-escalation trial using doses of 12 to 18 gray, along with concurrent immunotherapy, and their preliminary report of a very high local control of 98% and no toxicity at 6 months. And I guess the final conclusion would be that patients with brainstem metastases can be included in future trials, and it shouldn't be an automatic exclusion criteria. And thank you very much for your time and attention.